Good evening and welcome to NMA EyeTV. My name is Dr. Aaron Dotson and I'm one of the co-moderators for this evening episode. I also have joining here with me Dr. Daniel Laroche. Dr. Laroche, if you could just introduce yourself.
Hello, my name is Dr. Daniel Laroche, co-moderator at NMA EyeTV, glaucoma specialist in New York City. Thank you. Great to be here with the both of you today.
Excellent. And tonight we have a very exciting episode where we will be talking about glaucoma and what you need to know. What is glaucoma? How do you diagnose glaucoma? How do you treat glaucoma? I'm very excited to introduce one of my colleagues and friends, Dr. Tony V, who is a glaucoma specialist who's coming in from New York. So Dr. V here, he is a Helen and Martin Kimmel Assistant Professor of Ophthalmology at Columbia University Irving Medical Center. And he's also an attending ophthalmologist at the New York Presbyterian Hospital in New York, New York. His surgical expertise includes traditional glaucoma surgery, minimally invasive glaucoma surgery, glaucoma laser surgery, as well as cataract surgery. Originally from Bethesda, Maryland, Dr. V received his Bachelor's of Science in Biology from Yale University. He then went on to get his MD from Columbia. He was then elected as to be a part of the Alpha Omega Alpha Medical Honor Society. He then completed his internship at the Memorial Sloan Kettering Cancer Center and then completed his residency in ophthalmology at New York Presbyterian Columbia University Irving Medical Center, where he served as the chief resident in his final year. He finally completed his fellowship in glaucoma training at the Johns Hopkins Wilmer Eye Institute in Baltimore, Maryland. We are very, very excited to have Dr. Tony V here with us today. And without further ado, actually, before we get there, just to talk about a few additional ground rules here for tonight. So remember, guys, we are live here with NMA EyeTV. We do have a comment section that is here. So if you have any questions that come up throughout the stream for this evening, feel free to post them within the comment section. But we ask for you to be as respectful as possible. So without further ado, Dr. Tony V, if you could introduce yourself and we'll get things started.
Sure. Thank you so much for that introduction. It's really an honor to be here. Let's go ahead and pull up the slides.
Yes.
Awesome. Okay, so I'm going to be talking about glaucoma awareness, what you need to know. January is actually Glaucoma Awareness Month, so it feels very important that we're having this conversation today. I have no relevant financial disclosures regarding this presentation. I will, however, be referencing materials that are provided by the American Academy of Ophthalmology and the American Glaucoma Society websites, which are publicly available to all of you as well. So who am I? I am a glaucoma specialist. You kind of got the introduction from Dr. Dotson, but I did my undergrad at Yale, did medical school at Columbia. I stuck around in New York City for residency, also at Columbia. After 8 years at Columbia, I decided that I had to go learn from some other people. And so I went down south to Baltimore, where I completed a glaucoma fellowship at the Wilmer Eye Institute at Johns Hopkins. I am now actually an assistant professor of ophthalmology at Columbia, where I teach residents and fellows about glaucoma, as well as take care of patients, both medically and surgically, who have cataract and glaucoma. So I'll start with giving an overview of what we'll talk about. For our agenda today, we'll start by talking about what is glaucoma, what does that mean? We'll talk a little bit about why glaucoma matters, both in general to any patient and also for patients of African descent. We'll talk a little bit about the different types of glaucoma. There are a lot, so I'll keep it pretty high level. And we'll talk about what the eye pressure has to do with glaucoma. Many people are told that they have high eye pressure and sort of equate that with glaucoma, but I'll talk a little bit about how that's true and how there are some exceptions to that rule. Next, I'll talk about risk factors for glaucoma, so that you can kind of understand who's at risk for developing the disease. And we'll talk about symptoms of glaucoma, which are, spoiler alert, largely none. Next up, we'll talk about both diagnosis and glaucoma. I'll show you some pictures of how we test for glaucoma, the various machines and devices and sort of printouts and information that we use before going into treatment modalities for glaucoma. I'll finish off by talking about future directions for glaucoma therapy. It's 2024. There are a lot of really interesting and really exciting research projects that are happening now. And so I think that we'll be able to completely change how we think about this disease in the coming decades. I'll finish off with a quick conclusion, and then we'll open it up for questions. So what is glaucoma? Glaucoma is a disease of the optic nerve. That's the cable that connects the eye to the brain. And basically in glaucoma, that cable that transmits visual information stops working. So what you can see here in this diagram, this is the outside of the eye. You've got your lens here. You've got your retina, which is the camera film of the eye. And then you have your optic nerve. Light enters the eye through the cornea and the lens and hits the retina, the camera film. All of that information is then synthesized and sent to the retinal ganglion cells. Those are the cells that then transmit visual information to higher order imaging processing clusters in the brain. In glaucoma, for whatever reason, these retinal ganglion cells start to die. And unfortunately, those cells are not replaced after they die. So any losses of the retinal ganglion cells are unfortunately permanent. What that means for you clinically is that if you do have glaucoma and you do have retinal ganglion cell loss, that can lead to irreversible vision loss. Now, one of my symbols here is missing, but what it's supposed to say down here is that glaucoma is not the same thing as cataract. Cataract is basically cloudiness of the crystal lens. Glaucoma is a disease of the optic nerve. Many people don't know the difference, or sometimes it's hard to know the difference on family history. You know, did grandma have one or the other? But I do like to clarify with all of my patients that there is a difference, though they can be related, as we'll talk about later. So why does glaucoma matter? Why are we doing a lecture series about glaucoma? Well, there are approximately 3 million people in the United States and over 80 million people worldwide who have glaucoma. Glaucoma is often referred to as the sneaky thief of sight. And the reason it has that name is because the disease is asymptomatic or has no symptoms in very early stages or even in moderate stages. Because of that, half of people who have glaucoma don't know that they have glaucoma. Their eyes don't hurt. They're not conscious of any vision loss. So they don't know that there's a problem. Glaucoma is one of the leading causes of blindness, both in the United States and in the world. And it's one of the leading causes of irreversible or permanent blindness, both in the United States and in the world. Glaucoma, I like to think about glaucoma sort of the same way I think about high blood pressure or diabetes. Those are diseases that you can have as you get older. And you have to take medicine in order to keep them controlled. But if those diseases are controlled, they shouldn't really affect you too much day to day. And I like to think about glaucoma in a similar sort of way. It's a chronic disease that requires long-term control. But if you're able to control the disease, you really shouldn't have many problems. Why does glaucoma specifically matter to people who are African American or African Caribbean or African descent at all? Well, unfortunately, African-derived people have 3 to 4 times as much open-angle glaucoma compared to European-derived people. And you can see here in this chart that starting at around age 50, the prevalence of open-angle glaucoma in both African-American men and African-American women begins to rise. And that prevalence stays higher than all Caucasian men and all Caucasian women, regardless of the age after 50 years of age. It's kind of hard to tell here, but you can also see that the prevalence here starts to rise much earlier. We think of glaucoma as a disease mostly of people who are older, 65, 70, 75 and up. But you can see even starting at around age 50, the prevalence of glaucoma begins to rise in patients of African descent. What does that mean? Well, when you think about glaucoma, we think about vision loss. And studies have shown that about 5% of European-derived individuals who have glaucoma lose the ability to read in both eyes, meaning that with both eyes open, they're not able to read a standard newspaper. Unfortunately, that number is actually 3 times higher in patients of African descent. So we're more likely to lose our reading vision compared to patients of European descent. Glaucoma in patients of African descent, like I said earlier, tends to start earlier and tends to be more aggressive. Treatment can be challenging in patients like us. So it's important to make the diagnosis early so that we're able to intervene. What is eye pressure? And how does it play a role in glaucoma management? Well, our eyes have a pressure that keeps them round and healthy. It helps nourish the tissues. And you need to have some eye pressure in order for you to be able to see. Now, there's a normal range of pressure somewhere between 8 and 21 millimeters of mercury. And that balance is maintained by making sure that the amount of aqueous fluid or fluid that's inside the eye, that's different from tears on the outside of the eye, fluid inside the eye, that production is roughly equivalent to the amount of fluid that's leaving the eye. And you can imagine if you have too much fluid that's being made inside the eye and not enough fluid leaving, then the pressure will build, which can affect glaucoma. One of the main risk factors for glaucoma is having high eye pressure, although we know from large clinical studies that that's not entirely the answer. There are some patients who are called ocular hypertensives, which basically means your eye has a high pressure. Some of these patients have really high pressures and they never get glaucoma. On the other hand, there are some patients who have normal glaucoma or normal eye pressures who do develop glaucoma. And even with their normal or sometimes low pressures, their glaucoma still gets worse. So the eye pressure is part of it, but it's probably not all of it. What is the rest of it? We don't completely understand. Researchers are working on that to see what other theories and what other treatments we can provide for people. But for now, eye pressure is really one of the main things that we can follow and is really the main thing that we can treat. Regardless of what your starting eye pressure is, we do know that lowering the eye pressure with whatever medicines, lasers, or surgeries is helpful for slowing and hopefully stopping the progression of vision loss from glaucoma. So what are the types of glaucoma? You've probably heard of open angle glaucoma and closed angle glaucoma. And broadly, those are the two main categories. And I'll throw in childhood glaucoma, which is sort of a separate entity will not be discussed today. The most common type of glaucoma, both in the world and for patients of African descent, is open angle, which is basically the natural drainage system in the eye, which is located approximately between the clear dome of the cornea, which is up front here, and the colored iris. For some people it's blue, some people it's brown. That drainage system is open, but probably there's some decreased outflow of the fluid that's made in the eye due to increased resistance or debris. It's hard to know. But again, this is the most common type of glaucoma. In closed angle glaucoma, that drainage system is actually closed. The iris and cornea can make contact and that drain is no longer available for fluid to leave. There are then other subtypes of glaucoma, like childhood glaucoma with developmental abnormalities or glaucomas that are caused by other medical conditions. One of the ones that I tend to see a lot as someone who practices at a large academic medical center is neovascular glaucoma in patients who have really bad diabetes that's not well controlled. Other types of glaucoma that you may see are steroid response, so people who are taking certain medications that causes the eye pressure to go up, people who've had direct trauma to the eyes, and then people who have inflammation like uveitis or other inflammatory conditions that can predispose them to glaucoma. Risk factors for glaucoma. Unfortunately, there's no single gene or environmental exposure that's linked to glaucoma. There's a lot of stuff that is associated with glaucoma risk. Some of the risk factors associated with increased risk of open angle glaucoma include advancing age, having a high eye pressure, having a family history, particularly a parent or even more important, a sibling who has open angle glaucoma, ancestry, particularly African ancestry, and interestingly, nearsightedness or myopia is the medical term. For patients who have increased risk of closed angle glaucoma, they also are at risk if they're getting older, if they have a direct family history. The ancestry for angle closure is a little bit different, typically Asian or Inuit descent. People who are farsighted or hyperopic is the medical term are also at increased risk. And there are certain anatomic properties of the eye. If the eye is very short, if some of the structures within the eye are very close together, that can predispose someone to angle closure and an angle closure attack. What are the symptoms of glaucoma? This is really important. In early stages of glaucoma and even moderate stages of glaucoma, most people don't know. They do not know that they have glaucoma. because they don't realize that their vision is changing. There's no eye pain, there's no eye redness, there's no tearing really. And the vision that's lost in the beginning stages of glaucoma, is the peripheral vision. It's the side vision. Well, for most people, we don't consciously use the side vision. It's something that we subconsciously use. But our central vision is maintained. So reading, watching TV, driving, all of those things are still doable visually, so people don't know. As the disease gets worse, that loss of peripheral vision will start to move centrally, meaning the vision loss will start to march inwards. And in very advanced disease, patients can be 20/20, they can read and watch TV, but they'll have tunnel vision. They're not able to see anything except for what's directly in front of them. Left untreated, glaucoma-related vision loss can cause complete blindness. And because it's a problem with the optic nerve, unfortunately, we don't have the technology right now to regenerate that tissue. So any vision loss that comes from glaucoma is unfortunately permanent. I'll make a quick highlight of acute angle closure because this is an ophthalmic emergency. Remember I was talking about the angle being open or closed? In acute angle closure, the drainage system for the eye essentially slams shut. There's no way for fluid that's being made in the eye to escape the eye, which can cause the eye pressure to rapidly increase. When that happens, patients will have blurry vision, a very red eye with tearing. The eye will be very, very pain, and there may be headache associated with that eye pain, usually behind or around the eye that's affected. Sometimes the pain is so severe that people are sick to their stomach with nausea and vomiting. This is, again, an emergency. The pressure is very, very high and must be decreased very rapidly. Otherwise, patients can suffer rapid and permanent vision loss. Acute angle closure glaucoma is treated in a myriad of ways. Usually, patients will go to their ophthalmologist or emergency room, and we try and lower the pressure with topical eye drops or IV medications, laser procedures, and in some cases, we actually have to go to the operating room in order to make a new drainage system for the fluid to leave the eye to lower the pressure and save the vision. One of the questions that I get asked a lot, particularly by patients who present to me with advanced visual field loss, is, will I lose my vision completely? Well, if you're watching or listening to this lecture, you will most likely not go blind for glaucoma because you're doing the right thing by learning about it and becoming aware about glaucoma. Most patients who lose functional vision from glaucoma are diagnosed late in their disease, and usually they have difficulty with the treatment, either because it's difficult to remember, it costs a lot of money, it's difficult to make it to appointments, etc. Patients who have advanced glaucoma may have difficulty with certain visual tasks. So remember I said that many patients who are very advanced have 20/20 vision. There may be changes to contrast sensitivity or certain sensitivities to ambient light that mean that it's very difficult to read. Patients who have advanced glaucoma have no peripheral vision at all, and so it becomes very dangerous for them to drive. They can't see when pedestrians are crossing into the street or see when cars are trying to make a left turn. And so they can get into accidents and harm themselves and other people. However, if you're someone who's worried about glaucoma and or have glaucoma, and you're seeing an eye care specialist, you've already set yourself up for success. And that's what we're here to kind of promote here tonight. How do we diagnose glaucoma? Well, it needs a comprehensive eye exam by a trained eye specialist. The evaluation can actually be pretty extensive and involves a vision test. So that's the big E chart to see what your vision is, 20/20, 20/40, or better or worse. An eye pressure test, which I'll talk about in a little bit. Gonioscopy, which is a special type of test to check whether or not the angles, the drainage pathway for the eye is open or closed. A visual field test to assess for peripheral or side vision damage. And then optic nerve evaluation, so looking at the actual cable inside the eye, both clinically and with using a computer-based photo to quantify how much nerve tissue there is compared to people your same age. I'll start by talking about eye pressure. Eye pressure, again, is the thing that we can treat. That's really the one piece that's the one tool that we have in preventing further loss from glaucoma. Here pictured, there are a bunch of different types of devices that can be used to check eye pressure. Some require anesthesia, some require you to actually be in the eye clinic, some are very portable, some can be used in children. They all have their own pluses and minuses, but getting an eye pressure check is absolutely necessary for our glaucoma evaluation. Next up is gonioscopy. And many glaucoma specialists are comfortable with gonioscopy, but many comprehensive ophthalmologists or optometrists may not feel comfortable with this test. In the test, a contact lens mirror is placed on the eye, and that helps us visualize the drainage system to know if it's open or closed. Sometimes we can see evidence of prior closure events where there will be scar tissue in the angle or in the drainage system, and that may push us to treat you in one way versus another. The visual field test is one of the big ticket items for diagnosing glaucoma. Here on the left, you can see a patient with their head in a bowl here. This is the Humphrey Visual Field Analyzer. The test is done one eye at a time, and basically we give you a button, and your task is to look at a center light, and there will be flashing lights or sort of dim lights off to the side that if you see them, you're supposed to press the button. This is, we can't see through your eyes, and so this is our best guess for what you can and cannot see. And at the end of the test, we get a printout of where you can see well and where you may have some deficits that are concerning for glaucoma. I like to tell all my glaucoma patients that visual field testing is supposed to be hard. The visual field machine is designed to test right at the threshold of what you can and cannot see. So if you walk out of a visual field test feeling like you aced it, that's not such a great sign. Usually I know that patients have done well when they feel like they failed, and it's something that you just will get used to over time as you take more of these visual field tests. Lastly is the evaluation of the optic nerve, and that's done clinically, as you can see here with a photograph on the left, or with OCT, optical coherence tomography, which is a quantitative photo that can be trended over time. These exams are really important for us because it helps us look to see if there's change in the thickness of the nerve, to see if there's increase of this inner circle. Usually the circle is very small, this yellow white space in the center, but as you lose more nerve tissue, the circle will begin to expand because there are no more cells there to sort of support that. And so we look to see if that expansion is happening. Similarly, with the OCT photographs, we can trend you over time and see, are there certain regions of axonal tissue that are being lost that we can correlate then with clinical exam and visual field, and that helps us make decisions about treatment. Once you've seen a glaucoma specialist, you'll get one of the three following diagnoses: definitely glaucoma, definitely no glaucoma, or glaucoma suspect. What is a glaucoma suspect? These are patients who have some findings that are concerning for glaucoma without a full diagnosis of glaucoma. You don't meet all of the criteria. Some people have nerves that are very suspicious looking. Other people have a strong family history and high eye pressures. There are a lot of different reasons why someone can be labeled a glaucoma suspect. Helpfully, large clinical trials have helped us figure out how to stratify glaucoma suspects to see if someone's low risk, medium risk, or high risk for conversion to glaucoma at 5 years, for example. Here I pictured two of those risk calculators. This top one is based on the ocular hypertension treatment study, which was a very large clinical trial, and there are a couple of versions of these calculators. I've also highlighted Dr. Laroche, who's developed his own calculator that's available on his website. These calculators help both you as a patient and your provider decide, how frequently should you be seen, how frequently should you be getting tested, and whether treatment is right for you at that time. Let's talk about treatment. Unfortunately, there's no cure for glaucoma yet. We're working on it. But currently, the goal for glaucoma treatment is to stop the disease from getting worse and protect the vision. How do we do that? By lowering the pressure, usually with medicine, laser therapy, or surgery. A special note is that in patients who have angle closure glaucoma, meaning that drain is closed or almost closed, cataract surgery can actually be very helpful in alleviating high eye pressure and preventing you from having an angle closure attack. That's that scary eye emergency that I mentioned earlier. If, however, you delay cataract surgery, sometimes that can actually worsen certain types of glaucoma. There's one subtype called phacomorphic glaucoma, whereby the lens, the natural crystal lens, turns into a cataract. And that cataract reaches a size so big that fluid has a difficult time leaving the eye. The treatment for that, similar to angle closure, is cataract surgery. Let's start by talking about medicines. Most medicines come as eye drops, although there are a few pills that are available. And all of these medicines work to decrease the amount of fluid, or decrease the pressure in the eye, either by decreasing the amount of fluid that's produced or by increasing the amount of fluid that's leaving the eye. Eye drops, pills, and all medical therapies must be taken at least once daily. Many of the drops are twice daily, sometimes 3 times daily, in order to safely lower the eye pressure. They're generally well tolerated, but almost all of the eye drops have some known side effects. So depending on the class of medicine that you're given, there will be side effects that you have to look out for. And certain drops may be indicated or contraindicated depending on what medical stuff you have going on systemically. One important note is that in the picture, you can see that all of these drops, all of these medicines are in bottles. Bottles have preservative chemicals in them to help extend the shelf life and to prevent bacteria from growing in them so you don't accidentally infect your eye while you're administering the drop. We know that some of these preservative chemicals, when instilled into the eye over a long period of time, can cause irritation. So we're working on different formulations of these drops that don't have preservative chemicals, that are a little bit better tolerated than their preservative-containing compatriots. Next up is glaucoma laser. The eye pressure can be lowered using an in-office laser that you can see kind of in this picture here. And basically what the laser does is it's laser light therapy. We fire it at the natural drainage pathway of the eye, and we essentially stimulate your own immune system to do a cleanup job. It gets rid of dead cells and old debris and helps remodel the tissues that make up the drainage system to help increase the amount of fluid that's leaving. Large-scale clinical trials have actually shown that this laser therapy is just as effective as drops. Typically, we used to reserve it for people who were already on a couple medicines. Their pressure was still too high, and we'd say, okay, let's try the laser. Now, if you ask many glaucoma specialists, if they had glaucoma, they would want to start with a laser. So that's something to talk to your doctor about if you do develop glaucoma. The glaucoma laser can wear off over time, and there are different studies that show different percentages of duration depending on how far along you are from the laser. The laser can be repeated, but each application is a little less effective, and each duration of efficacy is a little bit shorter each time. The last category is surgery, and there are a couple of different categories of surgery. Remember, I mentioned cataract surgery for angle closure. And there's evidence to show that it's probably helpful for open angle glaucoma as well. Traditional glaucoma surgery involves making a new drain for fluid to leave the eye. We know that there's increased resistance in the original drain, so we just create a new one. And that way fluid has an easier time leaving the eye and helps lower the pressure. The two main categories of surgeries are trabeculectomy and tube shunt, and some of the shunts are pictured here in this picture. They're very effective at lowering the pressure, but they do come with risks of infection, inflammation, of bleeding. Sometimes they work really almost too well and the pressure can drop super low. So you do have to be cognizant of that when considering glaucoma surgery. There's a new generation of glaucoma surgery as well called minimally invasive glaucoma surgery, or MIGS. And these have really been developed to enhance the natural drainage pathway to lower the eye pressure. So we're not making a new drain, we're just trying to help your natural drain work a little bit better. They're typically performed with cataract surgery, although many of them can be performed alone. They're not much, but they tend to be safer than traditional glaucoma surgery, but they also tend to be a little less effective, again, because you're dealing with the natural drain rather than creating a whole new bypass track. It's important to remember that when considering glaucoma surgery, your surgeon will tailor their surgical selection based on your disease severity, as well as your own preference, depending on whether or not you can come to post-op visits, how sensitive you are to eye drops, and other concerns. What are some future directions? These are some of the reasons why I went into glaucoma, because there's so much interesting research and so many interesting clinical trials that are being developed or are available already. Currently, glaucoma treatment is really limited to preserving the vision that we have, again, through controlling the eye pressure. People are working on different ways of trying to lower that pressure by administering medicines through injections or implants to help reduce the medication burden. So, maybe instead of taking 2 drops twice a day, you get an injection in the eye every 3 months or every 6 months, and that helps keep the pressure under control. In the future, in the distant future, we hope to actually offer even more advanced technology to help protect the optic nerve from damage, which is called neuroprotection, or even reverse vision loss from glaucoma using optic nerve regeneration technologies. These technologies are honestly probably many decades away. The visual system is very complex, and so it's very difficult to protect and to regrow in a way that is functional, but hopefully we'll get there eventually. If you're interested in learning more, there's a lot of information on the internet about glaucoma, and I recommend that you start with the American Academy of Ophthalmology and the American Glaucoma Society web pages. There, they have a lot of information about glaucoma treatment, diagnosis, the different types of glaucoma, and they also have a lot of Q&As about what sort of exercise should I be doing? Are there certain activities that I should avoid? What are some things that I can tell my family if I'm worried about having glaucoma or if I'm worried about them having glaucoma? Another thing that you should do is you should ask your eye professional about screening for glaucoma. And if you do have glaucoma, encourage your family members to also get screened. It's not enough to just get checked for glasses. You want someone to really do all of those tests that I talked about earlier. Lastly, this is one of the things that I'm really interested in and I think is super important. Look for clinical trials at nearby medical centers or on clinicaltrials.gov to see how you can participate. Patients of African descent are generally underrepresented in all clinical trials across all medical specialties. In order to know that all of these drugs and therapies and procedures and everything work for us just as well as they work for everyone else, we have to show up and participate. So I think that it's important, if you feel comfortable, to investigate the opportunities that are available to you to help both yourself and future generations of patients. So just to wrap up here, since I know I've been talking for a while, glaucoma is a disease of the optic nerve. It can lead to permanent vision loss if it's not diagnosed and treated by a trained eye professional. Glaucoma does not hurt. In most cases, it's asymptomatic in early stages, which is why it's so important to get your eye exam and get a glaucoma screen by a trained individual. Patients of African descent tend to have more glaucoma, get glaucoma earlier, and have worse glaucoma. And that's something that we need to do research on and further understand. In order to diagnose glaucoma, there's a lot of testing involved, including checking the vision and the pressure, the visual fields, taking pictures, all of that. That's how we really know if you're someone who has glaucoma, doesn't have glaucoma, or are a glaucoma suspect who needs to be followed over time. There are a lot of different treatment options available for managing glaucoma, all with the goal of lowering the eye pressure and halting future vision loss. But hopefully, newer medications, devices, and technologies will completely change the way that we think about this disease and quite possibly cure it in the future. I'll open it up to questions from our audience and any questions from Dr. Dotson or Dr. Laroche who may have any comments.
Excellent presentation, Dr. B. We're very appreciative of your time and just talking with us more about glaucoma. I have a lot of patients, or just the general population in general, they know about high blood pressure. They know a little bit about diabetes, but very few people know about glaucoma. And I feel like that's one of the many reasons why tonight is so important. Dr. Laroche, with you also being a glaucoma specialist, do you have any thoughts, any comments at all with regards to the subspecialty, with what's going on now with treatment?
Yes, Aaron, thank you. First of all, Tony, that was an excellent overview. Great job. Congratulations. Thank you for your time with NMA EyeTV. Being a glaucoma specialist, I want to do a little deeper dive in some of the issues that you covered. So in terms of glaucoma, you're right. For the most part, it's asymptomatic. Sometimes people will accidentally cover one eye and notice that they can't see out of the other eye. By that time, they've lost a lot of vision in that respect. So that's why it's important to get checked, like you said. With angle closure, sometimes you can get redness and blurred vision acutely that can give you a clue. Now, we talked about retinal ganglion and cell death. These are the cells of the nerve that die. There's some interesting data out there that shows that as the eye pressure goes up, that triggers an autoimmune T cell reaction. T cell elevations go up that trigger autoimmune reaction to destroy the retinal ganglion cells. So that's why it's very important to keep the eye pressure down, like you spoke about. The mean normal intraocular pressure, if you touch your eye, is about 15 in most people. That can vary with different corneal thicknesses. But the mean intraocular pressure in patients with untreated glaucoma is 18. So when your pressure is like 18 or higher, you really want to pay attention to those patients in terms of glaucoma. You want to know what your eye pressure is. That's very important. The corneal thickness is very important. That's a major risk factor that's underappreciated. And normal corneal thickness is about 545 microns. People who have very thin corneas, about 5'11" or so, have a much higher risk of glaucoma. So it's very important for people to know their corneal thickness. You mentioned the calculators. Okay, do you use those calculators at all?
I do. I actually use them for all of my patients.
Which calculator do you use?
I usually use the Oates calculator. There's one on the Wilmer website, and that's the one that I was trained to use, but there are a bunch of different ones out there.
Okay. Now, I'm familiar with the Oates calculator, but with the Oates calculator, you have to have someone like yourself look at the optic nerve and do a visual field test. So the calculator that I came up with, the Laroche calculator, you don't need a specialist. You don't have to look at the optic nerve. You don't have to look at a visual field. It has a very high sensitivity and specificity. It's designed for optometrists, community screenings, people that don't have access to a visual field to help identify those high risk and low risk patients. And I try to use that in my office or my techs, and that will help determine who we want to do a visual field test or not to help sort of triage some of those patients. So consider that for your resident clinic in terms of teaching as well. Phacomorphic. This is when you have a large lens in the eye and you mentioned it becomes cataractous and very large. This is an underappreciated cause of glaucoma because a lot of time these lenses are clear but large. The person could have 20/20 vision. They have this large lens in the eye, and we don't want to do surgery because they have 20/20 vision. You don't want to do cataract surgery, but they have a large lens that's rubbing up against the iris, releasing pigment, blocking the drain. And so I think one of the things that my area of research in is early cataract surgery, clear lens extraction, and microinvasive glaucoma surgery. And I think this is the data that you mentioned with the MIGS that's coming out is a game changer with earlier cataract surgery and glaucoma. And compared to when I was training 25 years ago, cataract surgery was very dangerous. You can get a lot of complications. The machines weren't as good or techniques weren't as good. But nowadays, it's much safer. You can do cataract surgery in about 5 or 10 minutes in some cases. See within a couple of hours in that respects. And that lowers your eye pressure from about 2 to 3 points, which is the delta from 18 to 15 in most glaucoma patients. So I think we have to move to a paradigm of earlier cataract surgery in many of these patients that are over 50 years of age. And then one more comment. You mentioned about medications and lasers. And in patients with advanced glaucoma, we really have to move to some of the trabeculectomy and tube shunt surgery earlier on in those patients. So patients with advanced glaucoma, you really want to move to an earlier surgical paradigm in that respect to get control because those pressures need to be much, much lower. So I just wanted to do a little bit deeper dive on your excellent presentation, just to throw those pearls out there in that respects. My only question for you would be, what advice would you give to a younger person that's maybe interested in becoming an eye surgeon and pursuing ophthalmology? What advice would you give to maybe a young medical student or a college student that's watching this video and they're impressed by your presentation and they aspire to be like you? What advice would you give to that younger student?
Contact me. Contact any of us on here. I think I can speak for myself, but in some ways, I think I can speak for all three of us. mentorship is like really the name of the game here. And so if you're interested in something, you want to see more of something, we're here. You can shadow us, you can ask us questions. If you want to do research projects, we can help you out with that. And that's true at any stage, right? You don't have to be an ophthalmology resident in order to make that contact. You can be a high school student, you can be in college, you can basically be any stage. And if this is something that you're interested in, we're more than happy to have you come work with us. We need more people who look like us working in ophthalmology. And so every person who's interested should feel free. We're very approachable. We will respond to you and invite you to come join us.
Excellent. So we do have a question here in the chat. One question is, can you talk about progressive loss of vision, even if the pressures seem to be controlled?
So that's tough, right? We've talked about how eye pressure and eye pressure lowering is really the name of the game here. I think that there's some interesting data talking about, when we check the eye pressure, we're checking it in office hours. So office is open 8 a.m. to maybe 6 p.m. If we check your eye pressure throughout the day, it may fluctuate, but we're not able to check your eye pressure at home. Until now, there are some devices that are commercially available. One of them is the iCare Home. I don't work for iCare or those people, but I have seen patients who have used them, and you can check the pressure at home overnight. It's pretty easy. It's a handheld device. And for many patients, we find out that actually they're spiking at home. Their pressures are between 10 and 12 in the office, and then you see them you get their data for the week, and like every morning at like 6 in the morning, their pressure's like 45 or like 30 something. And then you know that you just missed that high pressure because the patient wasn't with you in the office. And aside from going home with that patient and checking yourself, you wouldn't know. But that's one of the things that I think is helpful. I think something that was presented both at the American Glaucoma Society meeting and the American Academy of Ophthalmology meeting recently is that it's probably not just the absolute value of the eye pressure, but there's also some effect on eye pressure fluctuation, meaning that if you treat someone with medicine or laser or therapy or surgical therapy, if you're able to blunt those fluctuations, that's probably healthier for the optic nerve. So it's not just the absolute number, but it's sort of the eye pressure control, which can be difficult to understand without having that iCare Home technology where you're constantly checking pressures and knowing what the fluctuation is before and after an intervention. But I think as we continue to do research, particularly on patients who have high eye pressure and glaucoma, normal eye pressure and glaucoma before and after initiating medicines or therapy, et cetera, I think that we'll learn a lot based on what is it about the eye pressure that's so important, and how can we change the eye pressure or control the eye pressure in new ways or even old ways in order to prevent people from losing further vision. Dr. Laroche, I don't know if you have comments on this as well.
Well, I think you gave a nice overview. The eye pressure is not just one number throughout the day. Like you said, it goes up and down throughout the day in that respects. And for me, knowing that, I'll add mentally in my mind, whatever your eye pressure during the day is, I'll add about 5 points, because just from sleeping at night, your pressure goes up by about 3 to 5 points. And so that's why I like to intervene with anybody with glaucoma surgically as early as possible. Cataract surgery, early cataract surgery in people over 50 is very important. If people have advanced glaucoma, in addition to the cataract surgery, the trabeculectomy or tube shot, that definitely lowers the pressure and blunts those diurnal fluctuations that can take place. And also you can sleep with your head up on one of those beds with a pillow wedge at about 45 degrees. That will take a couple of points off your eye pressure at night as well. So those are some little pearls there to help blunt that pressure. And then also, despite surgery, if you still need medications to lower the pressure, that means that surgery hasn't worked well enough and you're still having those diurnal peaks. You may need a second glaucoma operation thereafter. So that's the only thing I would add.
Excellent. I have another question. With glaucoma, we're usually focused on our older patients. However, you can get glaucoma even if you are a child and even for newborns. Are there certain signs and symptoms that, parents, grandparents, or pediatricians should be looking out for possible glaucoma in a newborn?
So I'd say for infantile glaucoma, there's like 3 things that you should be looking for. So epiphora and the other 2, those are sort of like the red flag for this patient is not developing normally. Oftentimes in infantile glaucoma, the eyes will actually be larger, and if you look at the corneal diameter, it'll be much larger. So those are kind of the things that would tip a pediatrician off, maybe not a parent, but a pediatrician off that there's a problem. I think one of the things that we sometimes don't talk about is how much family history or family genetics can play into glaucoma. So if you have a parent or an uncle or an aunt who was diagnosed early, let's say they got their diagnosis at 45, don't wait until you're 65 when most people are getting glaucoma. You may have a type of glaucoma that's going to affect you earlier. And so you just want to be cognizant of that, cognizant of your family history. And then, you go for your visit once at 40. If it's all normal, that's reassuring, but you should just kind of keep in the back of your head, I do have this family history. I should get checked every couple of years. And if there is any suspicion on one of the exams, that's when you want to start being seen more frequently, probably annually at that point.
Excellent. And then, I actually have another question here. Somebody somewhere is probably thinking it, but you sometimes hear in TV or sometimes in rap songs about smoking marijuana. Is there an effect of marijuana with regards to intraocular pressure and glaucoma? Somebody somewhere is thinking about it.
I don't know that we have any clinical trial data to support that. Dr. Laroche, do you know of any?
There are cannabinoid receptors in the eye. Smoking marijuana, John Merritt from down in the DC area did a lot of research in this area. Smoking marijuana, like every 2 to 3 hours, can lower the eye pressure. But the problem is you have the side effects from that. Okay, the side effects on the lungs, the side effects on your mind. And so, those side effects are too prohibitive in that respects. In Jamaica, there is an eye drop called Marinol, made from marijuana, but that has not undergone vigorous clinical trials. The eye drops and the surgeries that we have work much better. But in different parts of the world, like in the Caribbean, where people can't afford eye drops, they can't afford to go to a doctor, can't afford surgery, they tend to turn to herbs and things of that nature. And so, the herbs and medicines and marijuana has a lot of other medicinal properties that's good for epilepsy, anti-emesis in cancer patients, and things of that nature. And because it can lower the eye pressure a little bit, some people who don't have anything else can turn to that. But the surgery that we have is much more effective, much safer, much better, less side effects. Same with the medications that we have as well. So that is definitely the way to go. The American Glaucoma Society does not encourage marijuana use for the treatment of glaucoma, to be very clear. But like I said, if you're in a part of the world that doesn't have access to, the medications or surgery that we have, well, then, these other potential herbs, may be helpful to some people.
Excellent. Are there any other questions or any other thoughts that you guys want to talk about with regards to glaucoma?
I just want to say, Tony, you did a great job. And congratulations. Welcome to New York City.
Thank
and
you.
Wish you good luck at Columbia. And we'll just turn it over to Tony to close it out.
Yeah. So I do just want to, I do feel that it's important, this clinical trial business. I gave a talk last year on African and African-American representation in clinical trials. And I do feel that it's very important for us to participate in clinical trials that may be diagnostic trials to see if there are new ways of detecting glaucoma, that may be in large population-based studies, that may be in genetic and epigenetic-based studies, that may be new medicines or new surgical devices, new surgeries. I think that it's important for us to be represented in that, so that we know that that information is applicable to us, whatever the data shows, and so that we're represented in that space, so that we are part of those clinical trials. And hopefully some of us will be inspired to maybe run some of those clinical trials and address many of the unmet needs that affect our community, that may be maybe second tier or are just not being thought about by anyone else.
Excellent.
Okay, great.
Well, thank you so much, Dr. V, as well as to you, Dr. Laroche. This is NMA EyeTV. We thank you all for listening to our stream here. Our streams are broadcasted on YouTube, and you can actually watch the stream after it has concluded from the live session. Feel free to post comments, feel free to share this with family and friends, and feel free to let us know if there are any other eye topics that you want to learn about for the near future. Before we actually head out, we have one additional question here. What about nutritional and lifestyle ways with regards to glaucoma?
I don't know that anyone said no to cardiovascular exercise.
I would add diet is very important. Eating lots of salads, lots of vegetables, staying away from too much starch, having a good BMI, not being obese. Diet's very important. Cardiovascular exercise, walk 8,000 steps a day. Okay, make sure you get 8,000 steps in. And then also meditation. Meditation has been shown to lower the eye pressure and blood pressure by about 20%. You can meditate by taking deep breaths through your nose, closing your eyes in a comfortable place in your home for 10 to 15 minutes, deep breathing like that. That can lower your eye pressure by about 20%, reduce your stress hormones and catecholamines. So those are very important. Good question on that respects. And then also with this video, for those of you watching, please share with your friends, your family members. Please like, please subscribe, please get the word out, because we want to bring to you every month. We're going to bring you some new content and get information out to the community. And thank you, Dr.
And if you're overdue for an eye exam, please come on in.
Thank you, Dr. Valenzuela. Go ahead.
Excellent. Well, thank you all so much here once again. We look forward to bringing you more topics in the near future. This is NMA EyeTV. Have a wonderful week and have a happy 2024. Thank you.